Well, thank you very much for the kind introduction, and I'm delighted to be here. I'm glad it's this evening at 5 o'clock and not yesterday at 5 o'clock, where I'm pretty sure most of you wouldn't be here and you'd be watching the football. So I'm going to talk today about molecular, I'm going to talk today about molecular imaging in endocrine tumors, but I'm going to specifically focus on Theochromocytomas and Paragongliomas actually. So what is a Theochromocytoma? Well, a Theochromocytoma is a neuroendocrine tumor that arises from the adrenal medulla, and a paraganglioma, it refers to its extraadrenal counterpart. And that can arise from sympathetic or parasympathetic tissue, anywhere from the skull base to the pelvis. And these tumors can be multifocal at presentation, or they can be synchronous, which means a patient can present with a Theochromocytoma or paraganglioma, have it resected, and then years later present with another primary tumor. These tumors can also be malignant, and that's actually one of the biggest challenges that we face in clinical practice, is trying to differentiate or decide which of our patients have malignant tumors. They can also be associated with other tumors, such as renal cell carcinoma or gastrointestinal stromal tumors. Now, that's typically in the context of a syndrome. And actually, Theochromocytomas and paragangliomas are now considered to be the most heritable of all tumors, and approximately 40% of patients will have a germline genetic predisposition. Okay, so many of us will be aware of the genes implicated in the most common syndromic presentations of Theochromocytomas, such as the neurofibromatosis 1 gene or NF1 gene, which causes neurofibromatosis type 1, the RET gene, which causes multiple endocrine neoplasia type 2, and the VHL gene, which causes von Hippel-Lindau syndrome. And of course, these genes were first reported in the early 90s, but really it was the early 2000s that brought with it an era of genetic discovery. And we now know that there are over 15 genes implicated in hereditary Theochromocytoma and paraganglioma. So arguably the most important of the genetic in terms of changing clinical practice has been the discovery of the succinate dehydrogenase genes. So the succinate dehydrogenase genes includes 4 genes: STHA, STHB, STHC, and STHD. And each of these 4 genes encode their namesake protein, which form the succinate dehydrogenase enzyme complex. And normally this functions in the citric acid cycle to convert succinate to fumarate. But a mutation in any one of the 4 genes renders the enzyme complex ineffective, such that succinate can't be converted to fumarate. So you get pathological accumulation of succinate. And we now know that that's what drives tumorigenesis by promoting both pseudohypoxia and hypomethylation. And the STH genes are important in clinical practice because they account for 1/3 of all the hereditary cases that we see. They also predispose our patients to other tumors, such as kidney cancer and gastrointestinal stromal tumors, rarely pituitary tumors. And importantly, they give us as clinicians a guide to, as to which of our patients are more likely to develop malignant Theos and paragangliomas, because they confer a much higher risk of malignant tumors, estimated to be approximately 50%. And that's most commonly the STHB gene. And over the last decade or so, clinical observations have allowed us to see genotype-phenotype correlations. So we know, for example, that our patients with VHL, NF1, and RET gene mutations are much less likely to have extraadrenal or malignant tumors when compared to our STH gene mutation carriers. And this has allowed us to stratify management and surveillance protocols accordingly. So unsurprisingly, as the gene mutation will guide management, all patients who present with Theochromocytomas and paragangliomas under the age of 60 can be offered genetic testing here in the UK. If those patients are found to harbour a gene mutation, they'll automatically be offered lifelong follow-up, which will involve a combination of clinical surveillance, biochemical surveillance, and radiological surveillance. And that exact protocol will vary depending on the underlying gene mutation. Their first-degree family members will also be asked to come forward and be offered genetic screening. And if they're found to harbour the same gene mutation, they will also be entered into clinical surveillance. So you can start to see that our clinics are going to start getting very busy with both patients presenting with their tumours and their family members who may also carry gene mutations, putting them at risk of developing tumours over the course of their life. So what do these tumours look like? What do these tumours look like on conventional cross-sectional imaging? Well, if we look at paragangliomas, we know they can be located anywhere from the skull base to the bladder, They're vascular tumors, so we'll typically see enhancement post-contrast on CT. We'll typically see low signal on T1 weighted imaging on MRI, intermediate to high signal on T2 weighted MRI imaging, and they'll often enhance post-gadolinium. What about pheochromocytomas? Well, we know that there are very strict or defined radiological criteria, if you like, to characterize adrenal lesions. So, and that's important because we know that adrenal lesions are very common in clinical practice. And we typically will define or characterize an adrenal lesion as either being a lipid-rich benign adrenocortical adenoma or an indeterminate adrenal mass. And that's based on radiological characteristics. And the differential diagnosis for an indeterminate adrenal mass can include pheochromocytoma, but can also include adrenocortical carcinoma, an adrenal metastasis from another primary, or a lipid-poor adenoma. So the radiological criteria that I'm sure many of you will know, and I don't need to tell this audience, that we use to define whether an adrenal lesion is either a benign lipid-rich adenoma or an indeterminate adrenal lesion include a density of less than 10 Hounsfield units on a non-contrast CT, and washout of contrast in a triple phase CT of the adrenal, where we look for either a absolute washout of more than 60% or a relative washout of more than 40%, being in keeping of a benign lipid-rich adenoma. We can sometimes look at size and tumor heterogeneity, but these are less sensitive predictors of whether an adrenal lesion is a benign lipid-rich adenoma. Like everything in medicine, nothing is black and white, so there are some caveats to mention. I'm sorry. So we see rapid washout in pheochromocytomas because they are vascular tumors. So it's important to be aware of that because rapid washout in a pheochromocytoma may mimic a lipid-rich benign adenoma. Similarly, renal cell carcinoma metastases are also quite vascular. So they may also show rapid contrast washout, again, mimicking potentially a lipid-rich adenoma based on CT characteristics alone. So unsurprisingly, we may sometimes have to also employ some molecular imaging modalities to help confirm the diagnosis of a potential pheochromocytoma or paraganglioma. Again, there are limitations to our existing molecular imaging modalities, so I wanted to go through these before I move on to show you some of our research findings. So if we start with FDG PET CT, again, like many molecular imaging modalities, sensitivity will be affected by the size of the lesion that we're trying to characterize. So the smaller the lesion, the less sensitive the modality. And again, the sensitivity will also be affected by tumor necrosis. Really important to note that we know that there will be FDG uptake in some benign lipid-rich adenomas, particularly those that are cortisol secreting. We also know that we should expect to see FDG avidity in benign pheochromocytomas. So that means that FDG PET CT may not be helpful in differentiating a pheochromocytoma from a benign lipid-rich adenoma, from an adrenocortical carcinoma, from an adrenal metastasis. Another important thing to mention is that if we employ FDG PET CT in patients, for example, with elevated catecholamines in whom we're trying to locate an occult paraganglioma or pheochromocytoma, it's important to be aware that catecholamines can activate brown fat. And of course, brown fat can take up FDG. And in young females in particular, that brown fat is often located around the chest and lower neck area. So that might mask a small mediastinal or neck paraganglioma if there's significant brown fat activation. So something to be aware of. If we look at Mibg Spec Ct, again, because Mibg is aligned with Spec Ct, resolution will be poorer than with PET CT. So sensitivity, again, is typically poor for very small lesions. Important to note that Mibg is taken up through the norepinephrine transporter, and that transporter is expressed on normal adrenal tissue. So again, Mibg is not very useful for looking for small pheochromocytomas, for example, as we may see tracer uptake in the background from normal adrenal. The same is true for somatostatin receptor imaging, be that gallium dotatate PET CT or octreotide Spec CT, because we see an abundance of somatostatin receptor expression, both 2 and 5 in the normal adrenal tissue. So again, somatostatin receptor imaging is not very sensitive or specific, for looking for small pheochromocytomas. In fact, probably the only useful, or most useful molecular imaging modality for looking for small pheochromocytomas is 18F-DOPA PET-CT. And that's because the amino acid transporter is not expressed on normal adrenal tissue. So this tracer could actually be quite helpful for localizing small adrenal pheochromocytomas. Fortunately, it's not routinely available in clinical practice in the UK, but is used quite frequently in the US. So I've just mentioned the limitations of some of our molecular imaging modalities, or some of the caveats to be aware of when looking for or screening patients for pheochromocytomas and paragangliomas. But there's a further layer of complexity that we need to consider in patients with suspected hereditary pheochromocytomas and paragangliomas. And that's because some of the gene mutations that predispose to these pheochromocytomas and paragangliomas can also influence the expression of some of these ligands that we are imaging by using these molecular imaging tracers. So if we look at FDG PET-CT, pheochromocytomas and paragangliomas that harbor succinate dehydrogenase gene mutations, for example, these tumors will have truncated citric acid cycles, increased anaerobic glycolysis, and of course will have increased expression, therefore, of transporters such as glucose transporter 1 and hexokinase 2. So these tumors will be very, very avid on FDG PET-CT. Important to note that patients who harbor STHG mutations will that develop other tumors such as renal cell carcinoma or gastrointestinal stromal tumors, those tumors will also be very avid on FDG PET-CT, as well as pheochromocytomas and paragangliomas. If we look at Mibg Spec Ct, patients who harbor STHG mutations and VHLG mutations will have downregulation of the norepinephrine transporter. This is caused by hypermethylation in the promoter region of the gene that encodes that transporter. But this basically means that Mibg Spec Ct is not a sensitive molecular imaging modality for patients who harbor these gene mutations, because there'll be downregulation of the transporter that takes this tracer up. What about somatostatin receptor imaging? Oops. Sorry, can you still? I don't know what's happened there.
We can see the presentation.
We can see the acknowledgements, yeah.
Oh, I can't see anything at the moment.
Oh.
Okay. Oh, here we go. Can you see this now?
Yeah. It's back on.
Yeah, that's it.
Sorry about that. So octreotide Spec Ct or somatostatin receptor imaging then. So the good news is that this is quite a sensitive imaging modality for both sporadic and hereditary paragangliomas, with the caveat that I mentioned already, which is that it is not a sensitive imaging modality for small pheochromocytomas. Okay, so despite major advances in this field in the last 2 decades, there are still a number of areas of unmet clinical need, and some of these are in the diagnostic arena. So I hope to address some of these issues over the next 15 or so minutes. So if we think about our approach to bilateral adrenal lesions then, so I've mentioned that cross-sectional imaging can be helpful, but there are limitations, particularly if the tumors are small. It can be very difficult to characterize the adrenal lesions. I've mentioned that our existing molecular imaging techniques are also less able to differentiate between pathologies, for example, a pheochromocytoma versus an adrenocortical carcinoma or a benign lipid-rich adenoma. And this is quite a common challenge in my clinical practice, because I see lots of patients who have syndromes which predispose them to bilateral pheochromocytomas. But of course, as we see older patients, we know that they'll also be at risk of other pathologies, such as benign lipid-rich adenomas, which are quite common in the background population. So this is a challenge for me in my clinical practice, which is why I collaborated with Professor Grinnell, Russell Sinanaki, who's one of our PhD students, together with Gigi, Joseph, Enos, HK, and a number of others, to look at the role of 11C metamidate in indeterminate adrenal lesions. As many of you on this call will know, 11C metamidate PET-CT is currently being used to evaluate adrenocortical tumors, typically benign tumors that secrete aldosterone. And that's because this tracer is very sensitive for detecting adrenocortical tumors, because it binds to 2 enzymes, CYP11B1 and CYP11B2, which are exclusively expressed on adrenocortical cells. These enzymes are not expressed on the adrenal medulla. So that means that we could think about using 11C metamidate PET-CT to differentiate, for example, between a pheochromocytoma and an adrenocortical tumor. So I'm going to show you 2 examples of that in clinical practice. So this was a 37-year-old gentleman who presented from Eastern Europe, had a history of a RET gene mutation, so MEN2, and presented to his GP not long after arriving in the UK with symptoms of hypertension, with hypertension and symptoms of catecholamine excess. He was diagnosed with a larger left-sided indeterminate adrenal mass, which you could probably see here on this image, and a smaller right-sided adrenal nodule, best seen here on the axial zoomed image. So this patient had bilateral adrenal lesions. The left-sided lesion was quite convincing for a pheochromocytoma, and he did have elevated catecholamines. But the right-sided adrenal lesion was difficult to characterize because it was small on CT and remained indeterminate. Of course, for us, it was really important that we figured out whether this was a second pheochromocytoma, because if it was, he would need a bilateral adrenalectomy. But equally, we wanted to make sure it wasn't a benign pathology like a lipid-rich adenoma, which would spare this patient from needing a bilateral adrenalectomy and lifelong glucocorticoid and mineralocorticoid replacement. So we went on to do 11C metamidate PET CT. So you can see on this image here that the large left-sided adrenal lesion was cold on 11C metamidate, which we would have expected because we thought this was a pheochromocytoma. And if you can see probably best, on this image here, this is the right-sided nodule. This was also cold on 11C metamidate, suggesting that this was not adrenocortical, that this was most likely either a medullary tumor or a non-adrenocortical tumor. Mibg Spec Ct helped us further because we could see uptake in the larger left-sided adrenal lesion, again in keeping with the pheochromocytoma. And we were just about convinced that there was some uptake in the right-sided lesion, in keeping with the lack of tracer uptake on 11C metamidate. This supported the diagnosis of a pheochromocytoma on the right side as well. So this patient had a bilateral adrenalectomy supported by these imaging techniques, and indeed histologically was confirmed to have had bilateral pheochromocytomas. So if we look at this next case, this was an older lady. She was in her early 70s. She again also presented with symptoms of catecholamine excess. She had a history of renal cell carcinoma, which had been resected a number of years previous. So you can see that this patient, probably best seen on this image here, had a larger right-sided lesion and a much smaller left-sided nodule, which you can see here. So the right-sided lesion was quite convincing for a pheochromocytoma, again was indeterminate by radiological characteristics on CT, but again the left-sided lesion was small and difficult to characterize. Again, similar to the last patient, very important that we got the diagnosis right here to determine her management. And of course, there was the added complexity in this case that the lesion on the right side, for example, on the left side, could have been an adrenal metastasis. So we went on to do 11C metamidate again in this case. So you can see that there's there's no tracer uptake in the left-sided lesion, in the right-sided lesion in keeping with the pheochromocytoma. What we see on the left side here is quite avid uptake in this small nodule, supporting the diagnosis of an adrenocortical tumor on that side. FDG PET was also performed, which showed high FDG avidity in the right-sided lesion, supporting the diagnosis of a pheochromocytoma, but not very much avidity in the left-sided lesion, supporting the diagnosis of a potential lipid-rich benign adenoma on that side. So we discussed with the lady that it would be appropriate for her to have the right-sided pheo resected and the left-sided nodule monitored, because the imaging suggested that this was most likely a lipid-rich adrenocortical adenoma. But given her history, she was quite keen to proceed with bilateral adrenalectomy. And histologically, sorry, I don't know, it's my computer, sorry. Histologically, the right-sided lesion was confirmed as a pheochromocytoma, and the left-sided lesion was confirmed as a lipid-poor, actually, adrenocortical adenoma. But this correlated with what we found on imaging. So this suggests that using a combination of molecular imaging modalities, including 11C metamidate, might help us better differentiate between adrenal pathologies so that we can make the correct management decisions for our patients. So what about localizing occult pheochromocytomas and paragangliomas then, and staging patients with suspected metastatic disease? So this is a very interesting case, and thanks to Enos, who gave me her slides, which unfortunately, I don't know why, I'm sorry, I'm jumping around the place. But this is a patient who presented shortly after giving birth to her second child with hypertension, again was diagnosed with elevated catecholamines. Conventional cross-sectional imaging failed to identify a Theochromocytoma or a Paragonglioma, so we moved to molecular imaging. So we decided to do FDG PET CT first, and what you can see here is quite marked uptake of FDG in activated brown fat in this lady. So what was most obvious on the FDG PET CT initially was this lesion here, which was located between the bladder and the uterus. And you can see quite high FDG avidity, which was suggestive of a potential gynecological malignancy. This was an unusual location for a paraganglioma, so we weren't convinced that this was the cause of her elevated catecholamines. So we initially referred her to the gynae MDT, and we proceeded to do a dose-tape PET CT. And what you can see here is that what's very obvious in the dose-tape PET CT and was not as obvious on the FDG PET CT is this paratracheal node. And this was being partly masked by that brown fat activation that I mentioned on the FDG PET CT. What's interesting as well is that this lesion between the bladder and the uterus was not avid on dose-tape PET CT. So we figured that this patient probably had a dual diagnosis at this point. We thought she probably had a paratracheal paraganglioma and a separate gynecological malignancy. So because of the elevated catecholamines, we proceeded initially to remove the paratracheal paraganglioma, but we were all very surprised when post-op, her catecholamines did not normalize. So we went back to the drawing board, went back to the MDT, and we all looked at the images again, and there was no other focus of abnormality on the on either PET, either dose-tape PET CT or FDG PET CT or cross-sectional imaging, other than this lesion between the uterus and the bladder. So given that this was very FDG avid and likely needed to be operated on anyway, we alpha blocked the patient, and she proceeded with surgery under both gynecology and urology. And actually this transpired to be a bladder paraganglioma, which was extending out of her, beyond her bladder, if you like. But what's very interesting is that it was not avid in dose-tape PET CT. And we think, or the most likely explanation for this, is that histologically the bladder paraganglioma looked much more aggressive than the mediastinal paraganglioma, both in terms of proliferation index and other markers of malignancy. So it's possible that this bladder paraganglioma had started to dedifferentiate, was no longer expressing somatostatin receptors, which is why we saw it show avidity on FDG PET, but not dose-tape PET CT. And this really highlights that in some cases, we may need to consider using both FDG PET CT and dose-tape PET CT. Moving on to another case, these two cases really highlight one of the issues I mentioned earlier with Mibg Spec Ct. So this is a 45-year-old gentleman. He presented about 25 years ago now, when he was in his early 20s, to another hospital in London. He had symptoms of hypertension, was diagnosed with a paraganglioma, and had it resected. 25 years ago, of course, genetic testing would not have been commonplace, and he was actually lost to follow-up. But fortunately for him, his GP had taken a keen interest in this rare tumor and was doing ad hoc urinary metanephrine levels on him. And in 2018, found his levels to be abnormal and referred him into my clinic. He initially had an Mibg Spec Ct, which showed no abnormality. But because he was very young when he first presented with an extraadrenal tumor, and because his biochemistry was so unequivocally abnormal, we proceeded to do an FDG PET CT, which identified this single rib metastases, which was recurrence of his original paraganglioma. And thankfully, he underwent complete resection. He had a rib resection, and he remains cured to date. He was confirmed to have a germline STHA gene mutation, which is why his Mibg Spec Ct was not sensitive in this case. Second case, 20-year-old woman, again presented recently with hypertension, no family history. She had elevated catecholamine levels. And before she was referred to our center, she had an Mibg Spec Ct, which didn't show any abnormality. Again, very young, very high levels. So we proceeded to dose-tape PET CT. And here, as you can see, she had a very convincing dose-tape avid exophytic bladder mass. And as you can see from this image here, we're also able to see some local lymph node involvement. So this patient actually had a metastatic bladder paraganglioma, required a total cystectomy and lymph node resection, and also has a germline STHB gene mutation, again explaining why Mibg was so poorly sensitive in this case. So what about differentiating paragangliomas from other tumor types in our syndromic patients who may be at risk of multiple other tumors? Let's take a look at this case. This is a 25-year-old female. So she presented when she was 15 years of age with an upper GI bleed and was unfortunately diagnosed with a large gastrointestinal stromal tumor. Of course, her young age prompted genetic testing and she was found to have an STH mutation. In 2011, she had recurrence of her GIST at the surgical site, and they also noted a small mediastinal nodule. At the time, the MDT opted for surgical excision of the recurrence at the surgical site and to continue monitoring the mediastinal nodule. This remained relatively stable until March 2019, when an FDG PET-CT revealed that the mass had increased in size and was very FDG avid, as you can see here. So this was when I became involved in her case. And of course, the question at this point was whether this was truly recurrence of her GIST or whether this was a synchronous paraganglioma in a patient who had a germline STH mutation. Biopsy was technically difficult, so we went on to do some biochemical testing. Her plasma mets were negative, but important to say that some paragangliomas, particularly those arising from parasympathetic tissue, which can be those located in the mediastinum and the neck, are often non-secretory. So one of the questions that was posed to us at the time was whether gallium dotatate PET-CT might be helpful to determine whether this was indeed a GIST recurrence or a paraganglioma. And at the time, we didn't know the answer to that question because there was some data in the literature to suggest that somatostatin receptor expression, especially ex vivo, can be seen in these GIST tumors. So we didn't know whether dotatate PET-CT would help us differentiate between a paraganglioma and a GIST. So together with Gigi, Ines, HK, Joseph, Olivia, and a few others, we set out to try and answer this question. So we carried out a prospective study to investigate the role of gallium dotatate PET-CT in patients with metastatic GIST. We recruited 12 patients, including 10 patients who had STH mutations. And what we found was gallium dotatate PET-CT was not sensitive for the detection of gastrointestinal stromal tumors. So this tracer was not taken up by gastrointestinal stromal tumors. Here we can see some examples. So this is a patient with a metastatic GIST, and you can see imaging using both 18-FDG PET-CT and dotatate PET-CT. So you can see that the liver lesions are very avid on FDG, but not avid at all on dotatate PET-CT. Another example here of a patient with liver metastases that are photopenic, if you like, on dotatate PET. But this was an interesting case for us. So this is a patient who has metastatic gastrointestinal stromal tumor and also a synchronous carotid paraganglioma up here. So you can see on 18-FDG PET-CT that both the carotid paraganglioma and the metastatic GIST are avid. But on dotatate, we see much higher avidity in the carotid paraganglioma, some avidity in one or two liver lesions, but it should be noted that we didn't biopsy all the liver lesions, so we're not entirely sure if some of these liver lesions may have been related to the paraganglioma and not the GIST. But basically, we concluded from this study that dotatate PET-CT can be used and is likely to be helpful to differentiate a GIST from a synchronous paraganglioma, because we'd expect dotatate avidity in a paraganglioma, but not in a GIST. So going back to our original patient then, she went on to have a dotatate PET-CT, which, as you can see, the mediastinal mass was very avid. We actually picked up also a nearby lymph node, and she underwent surgical excision, and histology confirmed that this was indeed a primary metastatic paraganglioma, not recurrence of her GIST. Finally, this is the last section. So I wanted to discuss the role of molecular imaging in helping us to diagnose these hereditary tumors at an earlier stage. So I mentioned earlier that mutations in the succinate dehydrogenase genes affect the succinate dehydrogenase enzyme complex and result in accumulation of succinate. Therefore, you could use succinate accumulation in a tumor as a marker that that patient has an SDH mutation. And indeed, we have shown this using ex vivo metabolomics. This was carried out in collaboration with Mibg Spec, who I think is on the call. We used solid-state Mri Spectroscopy, and we looked at almost 100 tumors. And what we saw was that we could clearly see succinate accumulation in the SDH mutation tumors, but not in the wild-type tumors. And we were able to calculate a concentration of succinate, which was greater than 0.78 millimolar, which differentiated STH mutation tumors from wild type tumors. So armed with this information, we wanted to examine this in vivo. So look for succinate accumulation in tumors in patients before they've had surgery, because it may alter their management. And I did this in collaboration with Mary McLean and Ferdy Gallagher about 2 or 3 years ago now during my PhD. And this is an example of such a case. So this is a 26-year-old male who presented with abdominal pain shortly after running the London Marathon in about 2017. He was diagnosed with this large retroperitoneal mass. Catecholamines were elevated, confirming that this was a paraganglioma. And given his young age and extraadrenal location, we strongly suspected he had an STH mutation. Of course, genetic testing takes a couple of months. So we proceeded to MRI spectroscopy. And what you can see here is that in this tumor, there was definite succinate accumulation. There's a large lipid peak, as you might expect, because this is an abdominal tumor and there's going to be some fat. And we can also see choline, which is really important for us because we use this as a marker of a valid test, because choline should be present in living cells or living tissue. So armed with this information that this was likely an STH deficient tumor, we wanted to make sure the patient didn't have either occult metastases or a synchronous tumor. So we had an FDG PET CT, which showed that this retroperitoneal paraganglioma was very avid, but he also had a second synchronous carotid paraganglioma. So both tumors were successfully excised. Post-operatively, we confirmed again the presence of succinate in his tumors ex vivo, and this patient was also subsequently diagnosed with a germline STHB gene mutation. So we can use MRI spectroscopy and detection of succinate in vivo to identify patients who harbor these gene mutations very, very early. Final case. This is a 39-year-old male. He presented with bilateral renal tumors. He also had a family history of his dad having had renal cell carcinoma. So again, during my PhD, I did a piece of work where we saw that STHB gene mutations can predispose to renal cell carcinoma, and that can be the only phenotype, i.e. the patients don't always have to have Theochromocytomas or Paragangliomas. So given that this gentleman had bilateral renal tumors and was very young and had a family history, we quite suspected that he probably had an STHB gene mutation. Indeed, Anne Warren, one of our renal pathologists, looked at his tumor and she saw some pathognomonic features that we see in STHB deficient renal cell carcinoma, namely intracytoplasmic vacuoles, which you can see on this high-powered H&E slide here, but perhaps doesn't project very well. Here's one there. But what really perplexed us was that despite the phenotype and the histology, his STHB immunohistochemistry, which we would expect to stay negative, because if there was an STHB gene mutation, we'd expect that the expression of the protein would be absent or affected. Instead, in our case, we saw that the STHB protein was preserved in his tumor. So this patient had actually had a 2-stage surgery. So his first renal tumor was removed, but he had a remaining renal tumor that was planned for resection. So prior to that resection, we managed to do MRI spectroscopy on the remaining renal tumor. And that confirmed quite significant succinate accumulation in the remaining tumor. We went on to do germline genetic testing. What we found was that this patient has a pathogenic missense variant in the STHB gene. And further in silico protein prediction analysis has demonstrated that this particular gene mutation affects enzyme function, but does not truncate the protein, which was why we were seeing succinate accumulation in the MRI spectroscopy, but why we didn't see loss of expression of the protein on immunohistochemistry. So of course, this is a really, really important observation because it means we now know for patients presenting with this particular gene mutation in the future that STHB immunohistochemistry is not sensitive. And really highlights the role of metabolomics, both in vivo and ex vivo, for some of these cases. So take-home points. So POs and paragangliomas are rare endocrine tumors, and good outcome is really dependent on early detection. Detailed molecular classification can stratify surveillance and management for these patients, and targeted molecular imaging can further personalize diagnostic management approaches. So future directions, I think we remain very keen to investigate new functional imaging ligands, both in POs and paragangliomas and other endocrine tumors. I think there is huge potential to study enzyme flux in vivo, particularly in the tumors that might have citric acid cycle gene mutations. And I do also think that radiomics could potentially be exploited in these tumors as well to predict the genotype, because we know, for example, for the SGH gene mutations and VHL gene mutations, that there is significant upregulation of epithelial and vascular growth factors. So that might be translating into subtle differences in their imaging characteristics, which might be unveiled by radiomics. So I think that could be also an exciting avenue to explore in the future. So I'm going to finish by thanking all of my colleagues, many of whom are present on the call today. I'm not going to name you all individually, but I'm very grateful and feel very privileged to work with you all on a daily basis. And also thank you to the patients, and I'm happy to take any questions.